for the space. So two ways of circumventing this problem is you can use curved suctions that come from a different angle as the scope, and that way you don't have that fight so much, or you can make a space for the endoscope. And this is why sometimes we have to remove tissue from the nose just to make that space. Again, we don't open the space to see. You can see through a very small hole. We open the space to be able to move the instruments in a safe fashion. So at the end, you move the scope to the side. You still have the target in view, but more toward the periphery of the monitor, and you have much less of a fight when you are doing your surgery. So another way of looking at this is that if you imagine your nasal corridor being in this is an schematic. Let's imagine that we're looking at it in an axial view. Here we have the septum and the two nasal cavities with the sphenoid in the top. So when you do a sphenoidotomy, you will be able to move the instruments and a posterior septectomy. You should be able to move those instruments without any restriction to the lateral aspects of your field. Both instruments should not be constricted. If you do an inadequate sphenoidotomy, and usually we're doing a sphenoidotomy that gets to be flush with the lateral walls of the nose and lateral walls of the sphenoid. But if you don't do that, you see here that you will be constricted on the movement of your instruments. So why the sphenoidotomy? It is completely critical to be able to do the surgery, both in the lateral to lateral side and in the vertical dimension. Now, if you put that constriction a little bit closer to the nostrils, you can see here that you can still move your instruments to the side. And this is why in many of our surgeries, we can actually preserve the middle turbinates. We don't have to really remove them in every surgery, although we do when it's necessary. So, so adequate exposure, it requires that you take enough bone. Jokingly, we say that we take bone until we think it's too much, and then we take a little bit more. But you have to be cognizant that taking structures out of the nose can create some issues. So when we're looking at our corridor, we are also looking at the age of the patient. For those of you who do pediatrics, pediatric surgery, we know that the cranium develops much faster than the face and the sinuses. We know that the degree of pneumatization has to do something with age. As we age, usually by 15, you have an adult size type of sinus or an adult type of pneumatization, but pneumatization is also variable. So if you have something that has pneumatized like this, I think that your corridor will be fairly easy because nature have done a lot of the corridor for you. The patient will be highly pneumatized, patients with highly pneumatized sinuses. You just have to remove the septations in between, the walls in between, and you have an ample corridor. Now, we know that that's also variable. So we have the different types of pneumatization, for example, of the sphenoid, and what we call the conchal type of pneumatization, which is lack of pneumatization. It used to be thought that that's a contraindication for the endoscopic approach, but it's not so. You can actually pneumatize the sinus with the drill. Definitely the surgery, it becomes more difficult. The anatomical views, the identification of the anatomy becomes more difficult, but it can be done. So all these concepts that I just mentioned, especially the ones about exposure, have been proven in a practical way. Here you have an article from Dan Kelly in LA, and basically what he did here is he went back and reviewed all the cases that had been revision cases. Basically, the surgeons, the previous surgeons, failed to remove the tumor completely. And this even included his own cases. Why did he have to go and revise? And you can see here highlighted that the main reason in basically almost all the patients, over 90% of the patients, was inadequate exposure. So the patients had an inadequate sphenoidotomy, an inadequate celotomy, and that's what they were having the trouble. So if in the middle of the surgery you're having trouble moving your instruments, you're having trouble visualizing, you're having trouble with maybe getting slimed by blood or click-clacking the instruments, go back and go to the basics, start looking from the very front and see really how you can augment the exposure. And I mentioned before that it would be nice to be able to have maximum exposure all the time, but there is a price to pay if you do that, especially with functional epithelium. So we really are careful not to damage the olfactory function of the patients. And we can discuss about this a little bit more. We have different philosophies and on different aspects of the skull-based surgery on how to do that. But I can tell you that you should look at your technique. We have looked at ours, and basically we have a loss of olfaction of almost 0% with the technique that we use. So we're not going to dwell on this too much. By this time, you all know that we use 2 surgeons and a bimanual technique. Again, this is the critical concept. How you use the 2 surgeons and how you visualize and the rest, it's really you have to adapt it to your own circumstances and whether you are right-handed, left-handed, etc., etc. We try to have the surgical field or the nostril completely free, so all the cables are going away. My preference is to put it to the head of the patient, but if you prefer to do it to the side, one side or the other, that's okay. As long as this area over here is unencumbered by cables or other instruments. So I think that the benefits of a co-surgeon, again, you have to adapt to your circumstances, but having a co-surgeon really is a fantastic development for skull-based surgery. It improves visualization by moving the endoscope in and out. You have constant cues about your 3D. It increases the efficiency. And something that is underestimated is the second opinion from your co-pilot. And the best analogy that I have been able to come about is really just imagine that you're driving to work every day as we do, for most of us anyway. And one day you cannot drive and for some reason somebody else is driving you to work and you are a passenger. I guarantee you that as a passenger, you will see things that you had never seen as a driver. And the reason for that is that we're focusing especially on the road. So the buildings that surround that road, the trees that surround that road, many times go unseen. So your co-pilot is seeing at the panoramic picture, and by seeing the panoramic pictures, they may be able to predict or identify things that help you to have a better outcome or to avoid complications. So at the end, the idea is that you have 2 surgeons working together in such a way that at some point you will work automatically. You will really be able to predict what the other surgeon is doing, and really sometimes even confuse the hands that you're dealing with. I remember at some point of my career telling my co-surgeon, hey, listen, you have to suction that. And they look at me and say, hey, you have the suction. You do it. So these are things that are part of the development. How you place your instruments and your monitor in the OR, again, it depends on your circumstances, the space that you have, the equipment that you have, etc. Some of us will have a single monitor and it needs to be shared. We started by having a monitor at the head of the patient. I recommend you that you place it at the other side and a height that is lower than your eyes. That way you avoid straining your neck and you will have a much better experience and avoid having to go to physical therapy. If you have an OR that is equipped with multiple monitors, then every surgeon can have their own. And you can see here that our scheme is really to have the 2 surgeons where Danny Prevedello and I are both right-handed. We have more or less the same body habitus, and so we can accommodate ourselves on the same side of the patient. One goes to the slightly more toward the head, The other one is slightly more toward the side of the patient, where we both are there. We put the navigation at the head of the patient and the anesthesia. Nowadays, we have the anesthesia at the feet of the patient. So the patient is really at the 180 degrees. But again, this is something that you adapt according to your circumstances. I have seen and how you use the two surgeons and whether or not you are right-handed or left-handed. I have seen all the permutations and combinations of this, and they are all fine as long as you use them correctly, as long as that adapts to your circumstances. So again, we have also Brad Otto is a left-handed surgeon, so he goes to the other side. Now, for us, for him, that becomes a little bit of a hindrance because we like to really position the head in such a way that the head is kind of turned to the right side. I'm not going to dwell too much on the position of the OR instruments and such, just to tell you to try to organize it in such a way that in case of an emergency, all this doesn't really get on the way. So I was mentioning before that the position of the head. So for the most part, first of all, this patient is being monitored for cranial nerves, and that's why we are putting her on pins because it cannot be the patient cannot be paralyzed. But we don't do this in the great majority of patients. The great majority of patients are really on a horseshoe head holder without pins. But what illustrates here is the position of the head. We're going to translate that head anteriorly. That way, when you work, you don't have interference with the chest. Then we're going to tilt the head to the left side, and then we're going to turn the head to the right. So I cannot show you with my hands here, but the idea of this is really to have your wrist in a position that are more straight, that you're not turning the wrist or bending the wrist at an angle that will become uncomfortable. Again, something that's our preference, but you can, again, adapt it. For those of you who started with a microscope background, you will recognize that basically is the position that you would use for a microscopic approach. Again, positions of the hands and the endoscope, nothing interfering with the passage of the instruments at the bottom. Instruments, I'm not going to dwell too much on it because it varies quite a bit. And again, the list gets bigger and bigger. But I think that as we become more minimally invasive, we become more dependent on instrumentation. And this is something that is true around the world. If you can be a great surgeon, but if you don't have the right instruments to do the surgery, you may have more limitations on what you're going to do. Experience, of course, is key for some of the cases, especially oncologic cases or intradural cases. You need a lot of experience. These are not cases that if you haven't done before, this is not something you want to start with. Maybe you should get more mentoring before you do that. So the hemostasis is key in endoscopic surgery. It's key for any surgery, but in endoscopic surgery, because our lens is so close to the field, it becomes more important. We use everything that you see in this list. Obviously, vasoconstrictors, warm water irrigation. We have a bath is common in the orthopedic rooms to have it. We have is a device that really warms the water at whichever temperature you want. For us, is 42 degrees. When this was described, it was described to use it at 50 to 54 degrees, but that's not conducive to a happy brain. So we use it at 42. We don't know how that works, but we know that it either triggers a coagulation cascade or maybe induces some edema on the vessels, and the hemostasis improves, especially hemostasis that have to do with capillaries. Elevation of the bed, this is also a very useful technique. I put here 30 degrees, but most of the time we're at less than that. Maybe 20 degrees is ideal. Remember though that if you every time you elevate the head, the cerebral perfusion may decrease. So you have to be careful when you have intradural disease, not to elevate the head too much, because your cerebral perfusion is gonna decrease to by some significant number. So all the other things, I think that hemostatic pastes, they are expensive. They may not be completely available, but you can make your own with gel foam, gelatin foam, or any other material. And it really has changed our life, especially for the control of bleeding of the venous sinuses. Since I'm talking to mostly otolaryngologists, we love hypotensive anesthesia, and it's a very useful technique, but we shouldn't use it for intradural pathology. And the reason is that when you have something intradural, that space occupying lesion is usually compressing something. So it is making something ischemic. So let's say, for example, a craniopharyngioma or a pituitary tumor that is growing suprasellar, and you have compression of the chiasm. they already have an ischemic effect. So if you use hypotensive anesthesia, that ischemia is going to increase. So you can do a great surgery and have a less favorable outcome because of that hypotension. So let me give you an idea of what the usual corridor is for us, especially for a pituitary surgery. So we start by usually outfracturing the inferior turbinate. I first infracture it and then outfracture it, doing it with the shaft of the instrument so you don't impale the turbinate. There's no biological price to do this, but it improves the passage of the instrument, and it improves the space that you have as a reservoir for blood. Usually on the left side, I also am going to go and outfracture the left superior turbinate, and the left superior and the middle turbinate. And what that does is it gives you access to the sphenoethmoid recess. You can see here the natural osseum of the sphenoid sinus on the left, as the instrument is pushing the sinuses, the turbinates to the side. Now, on the right side, we're going to decide, let me see if I can stop here. We're going to decide what we're going to do. Are we going to do the same thing? We can outfracture the turbinate. Well, it depends on the anatomy of the patient, and it depends on the pathology that I'm going to be dealing with. If I have something that is in the sella, and I have only in the sella, and I have this type of nasal anatomy, that corridor will be enough to really tackle that pathology. But if I have, let's say, the same pathology, but it's extending now to the cavernous sinus on the right side, I want to have full control of that carotid on the right side. Or if we have a pathology that is extending to the clivus, I may want to have more space for the instrumentation, again, unencumbered. So in those cases, I remove the turbinate, and in many, I will remove the ethmoids too, to give more space to the instruments and to the scope. So again, just look at the anatomy here, and let's say, let's see how it changes by removing the turbinate. So when I remove it, I remove usually the lower half of the turbinate, what hangs in the nose. Very careful not to go too high and damage the cribriform plate. So the resection of the turbinate is kind of a controlled avulsion, as you can see there. And as we remove the turbinate, then we're going to have all this space in the back. In some cases, we're going to remove the superior turbinate. In other cases, we're just going to outfracture it to the side. Again, it depends on the pathology we're dealing with. You can see here that, let me stop there for a second. At this point, you have to be thinking about what is the risk to the olfactory function, because you are removing some olfactory epithelium. About 80% of all the olfactory fibers are really in the septum. So that you're going to have to be more careful over there. If you pay attention, you can see these little ridges that are coming down. You can see the difference in color from the one mucosa to the other. And you can see if I would be able to move the scope, you can see that in the great majority of cases, the olfactory epithelium is actually elevated from the other epithelium. You can also see a different pattern on the vascular supply. Usually, this has some axial vascular supply, and this is more reticular vascular supply. So here we're gonna, if we make incisions in the septum, I'm gonna try to make them below the olfactory epithelium. So now we have created more space in this particular case, olfaction again, think of it. The other thing that we're gonna be thinking about is how are we gonna reconstruct? What type of defect we're gonna have at the end? So this, you can use free grafts or you can use flaps. I recommend you that develop the capacity to do either one of them. That way you don't have the limitation on how much exposure you're gonna create. And what I mean by this is when we only had the ability to have grafts, we were always thinking about what we had to leave to be able to place that graft in a fixed position. Well, now that we have a different flaps, I'm not thinking about that. I do the exposure that I need to do, and I'm not limiting my exposure because I don't have a way of reconstructing. So the other thing that has changed along the time, in 2006, when we started using the nasoseptal flap, I was using the nasoseptal flap for 85% of our cases. And the reason for that was that the nasoseptal flap pedicle, as you can see here, in between the natural ostium of the sphenoid and the posterior choana, this pedicle will be sacrificed if you do a posterior septectomy and a wide sphenoidotomy. So we were raising the flap at the very beginning to avoid damaging the pedicle. And once we had it raised, well, we were going to use it. Then we developed this other technique, the so-called rescue flap. Rescue flap technique, which is somewhat of a confusing term. People get confused. They think it's another flap. It's nothing but the posterior incisions of the nasoseptal flap. What we're rescuing is really the pedicle of the nasoseptal flap. So we make the incisions. You can make the superior, you can make the inferior incision if necessary. Usually just the superior is enough. Remember to do it below the olfactory epithelium so you don't cause olfactory function deficits. And then by doing that, you don't have to raise the flap. So if you do the two incisions, it looks like something like this. You can see that we can move that pedicle up or down. We could work in the sella in the back, up or down. We don't have to open the flap. We have a very wide sphenoidotomy in the back. And if we're using this technique, usually I preserve the mucosa of the sphenoid sinus, so I don't have crossing in the back, and I only move it from the sella. Now, if I'm going to use a flap, I'm going to remove all the intrasinus septations, and I'm going to remove the mucosa because I don't want a mucocele, and all these septations get on the way of the placement of the flap. So I'm going to remove it. So if I'm going to use a flap, again, because I'm doing a transplanar approach or it's a large transplanar approach, all the intersinus septations have to disappear. They do create some dead spaces for the position of the flap. So again, when you look at the sphenoid bone from the front, we're going to do these very wide sphenoidotomies that I always say that they look like the goalpost for rugby, and basically we want to really take it to the vertical post, and we really want to take it to that middle post. So very wide sphenoidotomy. So something that also I have seen people get confused is that they see this area here that usually comes with a vessel. That's the palatovaginal canal formed by the junction of the sphenoid bone and the sphenoid portion of the vertical segment of the palatine bone. As they join, they have a little fissure, and that's the palatovaginal fissure that carries the pharyngeal artery. So if you see what seems to be a foramen and some artery or nerve in that area, it is not the vidian. The vidian, to get to the vidian, you really have to go to the pterygopalatine fossa. So if you are in the nasal cavity, you are not seeing the vidian. In plain drilling, as I mentioned before, is important, and management of the sinus mucosa. Again, if you're not going to use a flap, you should preserve the mucosa as much as possible. Celotomy, if you're doing pituitary surgery, we always talk about the 4 blues. Basically, we take the celotomy to the cavernous sinuses laterally and to the superior and inferior cavernous sinus superiorly and inferiorly. So again, that has to be do with our technique. We remove not only the face of the cella, but we remove the bottom, and that allows us to work inside the cella in a much more free fashion and move the pituitary, the normal pituitary from the tumor a little bit less. So the use of Doppler, I highly recommend that you obtain one of these devices as opposed to the navigation. The Doppler will give you real-time information. And what I mean by this is that when we're using the navigation system, you are really using the images from before, the images that were taken preoperatively. When you use the Doppler, you're taking real life information. So it allows you to have the information about the pituitary, about the carotid or some other vessel of interest in a much more secure way. And of course, it's much more inexpensive. A navigation system will run you thousands of dollars, and you can get a Doppler system for less than $1,000. Removal of the tumor, I'm not going to dwell too much on it. Multiple techniques. We're fans of using the 2-suction technique, but we know that there are tumors that are not, they don't lend themselves to do that because they are more fibrotic. So you use whatever instrument is safe in your hands. So I guess that this is a good time to stop. We have been dealing with for 45 minutes, which is what I was asked to take. So maybe we'll stop here and entertain any questions that anybody may have.
So, Professor Carrau?
Yes.
So this is Johnny Kram. It was a fantastic lecture, Professor Carrau. And we're all your students. Yeah, so brilliant. Can I ask a few questions, Dr. Soma? Is it okay?
Yeah, sure. Go ahead.
Okay. So my first question to you is, we have been using the warm saline at 42 degrees for skull-based surgeries. Are there any studies which actually depict the injury to the ciliary motility in the nasal cilia?
Good question. I don't know of any, Jeremy. The use of warm saline started in Europe. I'm forgetting the name of the author who come up with the idea. And they came up with the idea for epistaxis. And this is something they do in the emergency room. And they found that it was extremely effective for posterior epistaxis. So they have been using it for quite a while. And as I mentioned before, they use actually a much higher temperature than what we use in skull base. I think that at 42 degrees, it would not make sense that it damages the cilia, but it's all theoretical. I don't know I don't know of a study that really has looked at that. It would be difficult to do because we do create some damage to the ciliary with surgery, right? So it will be hard to discern whether that's from the saline or the surgery itself. My suspicion is that it doesn't.
Okay. My second question to you is that you said that if you elevate the head, there can be a compromise to the cerebral circulation. But we see a lot of neurosurgeons operating in sitting position, especially for foramen magnum meningiomas. The sitting position is a very common position with neurosurgeons. So what's your comment about the sitting position surgery for even cavernous sinus? The only problem they say is the air embolism, which may occur. So what is your comment on that?
Yeah, that is true, but the anesthesiologist always pays attention to that. So for every number of centimeters that you elevate the head above the heart, a certain decrease in the cerebral perfusion, and I'm forgetting the exact number that is, but they do have into account. So what they do is they raise the blood pressure, or they try to maintain the patient as normotensive as possible, and that way they don't have problems with the cerebral perfusion.
Yeah. So one last question from my side, is that when we raise the nasoseptal flap, so when we make an incision either below the sphenoidos or above the choana, sometimes there's a lot of bleeding. So that we're scared that we've cut one branch, or maybe there's a viability of the flap or not. So there are two parts of this question. Number one is that is there just one branch of the posterior septal artery which actually supplies the whole nasoseptal flap? Hello?
No, go ahead. Go ahead. Yeah.
Yeah, you're still in.
Number two is that what is your experience on using this Image 1S Rubina for a fluorescence image to test the vascularity?
So in regards to the first question, first part, because I'm not too sure I understand the second one. The first part is like most of the time when you damage something is on the inferior incision, and usually it's the pharyngeal artery. It's not really the arteries that supplies the flap. But if for some reason you damage one of the branches, you are correct. Sometimes you can damage one of the branches, and you have multiple branches going in the nasoseptal flap, and usually they are enough to supply the flap. So it's not a full loss when you do that. I use the Doppler to really ascertain that I still have a flap when that happens, or if I have any question, especially in revision cases, in cases that somebody else did a sphenoidotomy before. Because if you're not attentive, some people, when they do the sphenoidotomy, send it down, they will take the artery. So to ascertain that I still have the artery, I use the Doppler on both sides. I do it in the lateral and in the septum and in between, and that way you're sure that you still have viability.
My second part of the question was just to address that. Carl Stoers is bringing out a camera called the Rubina, the next generation camera, where you can actually change the mode to see the vessel which is supplying the flap. So it's called the Rubina. So
so you mean by using ICG or just without?
Using
ICG.
Yes.
Yeah. So we have done that. I think that's useful. We don't use it all the time, but in cases that you have some question, it will be useful. The problem is that you have to raise the flap completely to be able to know whether or not you have viability, right? So it doesn't really help you at the very beginning, because if the flap, obviously the mucosa is alive somehow, so it may be the blood supply from some other vessel, the anterior ethmoidal, the palatine, or the facial, and you have a great ICG fluorescence. But it's not coming from your posterior artery.
Okay. Thank you, Professor Carrau.
Thank you, Dr. Janikaram. If I could just step back a little bit and just introduce the organizing committee of this SARC webinar series. Which you can see at the top of your screen, you have Dr. Leong Jern Lin from SNENT, Prof Wang from NUS, Prof Shetty, who's just joined us, you can see him on the screen, Prof Aldo Stam as well from Sao Paulo, David, myself, and Dr. Janikaram. So we welcome actually all the participants to the inaugural webinar today. It'll be a series of more than 10 sessions over the next 2 to 3 months. And before we actually go back to asking more questions, we'd like to thank our sponsors, for the 5 companies you see at the bottom: Manarani, You've got Abbott, Medtronic, and Olympus, as well as the Lee Foundation. So all our sponsors have allowed us to bring this to you today. So I would now like to introduce Professor Sethi, who has just joined us. You can see him on the screen. He was my teacher and one of the most eminent rhinologists and skull-based surgeons in this region. Previously a senior consultant at the Singapore General Hospital, now at Novena Specialist Center. Prof. Sethi.
Thanks, Soma. I apologize for having some problems logging in, but that's technology. It happens. First of all, Ricardo, thank you very much for joining us for this inaugural lecture today. Amazing, amazing lecture. And when I first met Ricardo, he was a star. Then I saw him become a superstar. Then he became a Nova, and now he's a supernova. Right? And I think his name is synonymous with skull-based surgery, and everyone doing a reconstruction, particularly, will at least mention his name 3 times during the reconstruction. So, Ricardo, you are the most talked name that one can ever come across. And thank you for joining us this evening. It's been a pleasure, hearing you talk, and thank you so much. The other pioneer we have today is Aldo Stam, and who is a great friend of mine, and we go back a long time. First met Aldo in 1997, so it's been 22 years of solid friendship. And Aldo, welcome. And Aldo will be speaking to us next week, and giving us a lecture next week. So I would like to open this forum to questions by the attendees. Who has access to the questions? Soma, do you have access to the questions?
Yeah, so just to the participants, you have a panel on your screen where you can just type in the questions, and we'll have them answered over the next few minutes. So in the meantime, do the moderators or the other panelists have any other questions, Prof. Aldo Stam or Prof. Sethi? Or any comments?
I have several questions for Aldo Stam.
But let me do the first question to Ricardo.
Yes, please. Yeah, let's make it interesting.
Yeah. Thank you very much, everybody, for inviting me, for especially the organizing committee of this fantastic webinar series, especially Dr. Sethi and Dr. Jana Kiran for inviting me, and Dr. Soma, Shin, etc. Ricardo, it was a great talk. Even Sunday early morning. It's a very nice talk. I learn a lot from you, of course. So all times when I listen to you, I learn many different things. Especially the basic principles of endonasal corridor for skull-based surgery. But I have some comments to you, and I am very happy you try now to preserve much more the middle turbinate and the intranasal anatomical structures, especially for lesions located at the middle line or the ventral skull base. And the great majority of the times, especially for tumors located in pituitary region, supracellular extension, even in clavus lesion, you can preserve the turbinates and the nasal septum. So basically, if you preserve the turbinates and you preserve the nasal septum one side, of course, you can preserve the olfaction of the patient. This is very important, is to increase the quality of life of the patient. Absolutely. Another very important comment for me is you mentioned in your presentation some instruments like a coarse diamond drill. The coarse diamond drill is really a very good drill, especially used for removing bone. I like very much diamond coarse drill for example, frontal sinus operation like a drag 3. So it works pretty nice. You need to remove the bone. But as an instrument, the coarse diamond drill is the most dangerous instrument for internal carotid artery. Especially we have a very thin bone, they destroy completely the dura and produce lesion of the internal carotid artery. This is my recommendation. It's an excellent instrument, but near to the carotid artery is really dangerous instruments for me. Another very important comment is regarding the use of vasoconstrictor in the nasal cavity or adrenaline as I use it. So I try to not to use adrenaline inside the dura. So you have many problems with the vasoconstriction inside the brain. So, and try to avoid the use of adrenaline and the olfactory groove. especially because it produces a very important vasoconstriction, and sometimes the patient lost the olfaction due to this cottonoids plate in the dural olfactory place. So this is the comments, because in our approach to preserve the septum, the one side of nasal septum, and then to avoid any problem of the need to remove the medial turbinate. There's another very important point in your corridor, approach is the main topic of your lecture today, is how to dealing with the nasal septum. For me, nasal septum endoscopic surgery is something like an elephant inside of your room. So you have the nasal septum inside of you, in front of you, with septal deviation, no deviation. I try to use the incision very anterior and displace complete the nasal septum. You will displace completely the nasal septum, remove the bony part of nasal septum, just preserve the cartilage. So you can have a very, very nice corridor, a very, very nice corridor. You can use both nostrils, create one flap on one side. So for me, nasal septum is exactly in the middle line and then the stubule. So you have to try to correct nasal septum and displace it laterally, then to get much more space. So this is really my opinion. But in general, I love your lecture, Ricardo. Congratulations again. And I learned many things, many basic concepts, and keep in touch.
Absolutely.
Thank you, Aldo. Ricardo, I just heard you your lecture the other day, a couple of days back, that you gave in Brazil and Omura was another Omura from Japan. He also gave a lecture on the same panel, on the same talk. And he showed some very interesting videos whereby he makes certain incisions onto the septum, removes the entire posterior nasal septum, and you get an incredible exposure. What do you say about that?
Depends on what pathology you want to use it for. The problem with that I saw with his incisions is that he destroys the possibility of the nasoseptal flap on both sides. And some of the pathology that he used, the incisions for, we just do it through one nostril. So
that's what I thought, and that's the reason for asking you the question.
Yeah, again, everybody, as I mentioned before, everybody has their own technique.
Yeah.
When I see a technique, and this goes with all those comments, is you have to see what is next and what is before, right? Because it's part of a package, it's part of a puzzle. So we have different ways of doing things, because that's not just that technique, not that step of the surgery. It's really the entire thing. It fits in the puzzle. So when I see Aldo doing the surgery, it may not fit into my puzzle the way that he does things. And likewise, when he sees me doing something, it doesn't fit. But when you look at the entire package, it fits nicely. So that was my only comment that I had about when he was showing things. Obviously, it works for him. It would not work for me.
Yes, actually, when we started doing the surgery way back in 1993, 94, we were just making a very small sphenoidotomy that was limited bilaterally by the superior turbinates. Forget about the middle turbinates. We never even touched the superior turbinate for concerns of olfaction. And we still continue to do that in most cases. And we are able to remove at least, I would say, 80 to 90% of the tumors, by even preserving the superior turbinates, and preserving olfaction for that matter. So is it necessary to do such extensive surgery when you can remove most 80 to 90% of the tumors just by a very conservative approach? What's your response to that?
We don't do that in every tumor. I mean, it depends on what you want to do. And I have seen you do it for tumors that I would remove the turbinate. Okay, we do it because I don't know, that's the way we do it. It's more comfortable. It's in our hands. We feel safer. And because we have proven that it doesn't really affect the olfaction in a significant fashion. It has to affect it somehow, right? You cannot take a tissue and expect that it's not it's going to be the same, but at least on the way that we can test olfaction, I can tell you that it is insignificant. When we look at our cases, it is not really significant. On the other hand, so going back to Aldo's point, you have to be careful though, for those of you who preserve the turbinate all the time. If you try to force the issue, we have seen patients on revision surgery have no olfaction and completely intact turbinates. And what has happened is that the surgeon went in and out, and they caused such a severe abrasion on the turbinates and the septum that now the patient has synechia, so the odorants cannot get into the olfactory epithelium anymore, and they have zero olfaction with completely preserved turbinates. So it is a balance. Again, we have gone back and forth on this, and we talk about theoreticals when we talk about this, and people get very passionate and visceral about it. I think that you have to be pragmatic. I agree that if you don't have to take it, please don't take it. Yes. It is functional epithelium. But if you're beginning, and if you are really uncomfortable with the situation that you have, and you are a beginning group, I think that you are safer taking the turbinate and making sure that you don't cause an injury. That's my opinion.
Yeah, I have a question to both Professor Aldo and Professor Carrau, and of course, if Professor Sethi could answer, it would be great. Now, Professor Aldo was talking about the use of coarse diamond burr, which can produce some harm on the carotid. We have seen people using punches, the rongers, over the cellar floor and also on the plenum. So, would any of you prefer using rongers to burrs? What is your take on that?
We use both. We use both.
Yeah,
So
yeah. I'm sorry, Ricardo. I'm sorry, Ricardo. Go ahead.
Yeah, sorry. So what we try to do is thin the bone enough that then you can remove it with a ronger, not using it as a biting instrument, but more as a hook. And again, you can make both things work. It depends on your technique. It's like the drills. The coarse drills works for us. It doesn't work for Aldo. That's okay. I mean, you have to be comfortable with the instruments you have. There are definitely some burrs that we avoid when drilling around the carotid. Same thing with the sella or the planum. We try to again thin out the bone until it sort of bounces. You can move it with your instrument, and then we remove it with whatever instrument that you can use in there. Sorry, Aldo.
No problem. Just a very short comment. When I drill over the internal carotid canal, you prefer to use the conventional diamond burr instead of the coarse diamond. So, and then keep this a very thin bone shell on, and then remove it with the Carrau punch.
So again, it's just preference, right? We don't like the diamond because you have to apply more pressure with the diamond, and it burns and the whole thing. But it works for you. You have made it work.
Yeah.
It's the same thing. And then the other thing I was going to mention is that there are two types of coarse diamond. You have the electronic coarse diamond, which is more aggressive, which I agree with Aldo. I would not use for a carotid or an optic nerve. And then you have the striker, which is less aggressive, and it's a different drill. It has less torque, so you don't have to apply so much pressure, and that works better for the places that are critical, like the carotid or the optic nerve.
If I may make a comment here, Janki, you may have listened to the talk the other day that I gave on Umar Tarabichis. And I showed some interesting videos of internal carotid artery injury. Now, in one of the videos, the surgeon actually exposed the carotid artery very nicely and then took a true cutting forceps and made a hole in it in trying to separate the tumor. And in another video, this person used a Doppler to identify the carotid artery beautifully and then stuck a knife right into it. I saw that video, right? It was as if he was identifying the carotid to stick a knife into it. So sometimes these things happen. It's a total disorientation. You can have a very good knowledge of the anatomy, and you can have the Doppler, and this is going to happen. And that's how it is.
No instrument is completely safe, right?
Exactly. I think it's like Professor Stemberger used to say, it is the hand behind the instrument, not the instrument. Hand behind the instrument. So, Soma, I think we should entertain some questions from the participants. Are there any at all, or?
You have to unmute yourself, Professor Soma.
Who has access to the questions from the delegates or attendees?
So actually, David has it. So we have one question about skull-base reconstruction. So the question is, if there's a previous complete septectomy, what would your preferred approaches be to reconstruction? Bit of a broad-based question, but Dr. Carrau and then Dr. Aldo and Dr. Janakiram, Dr. Sethi.
So a complete septectomy, I assume that's for oncologic purposes.
Yeah, the question didn't state the reason why.
So I don't reconstruct it. I don't. That would be a secondary reconstruction if the patient needs it. It is. I have a collection of these people, and it is really amazing that in the great majority of them, we don't have a saddle nose, and it may be because it may be that we preserve a little bit of a strut at the top over the nasal bones, but we don't get it. It's in the great majority. That's not to say that you can remove the system with impunity. That's not the case. We know that that's not going to happen in everybody, but in the great majority of the patients, they don't get a deformity.
Yeah. Yeah, Dr. Carrau, I think the question was, what would you do if you need to reconstruct the skull base if there was no subtle flap?
Well, it depends on what you are reconstructing. So you can use any of the variety of flaps. You can use lateral nasal wall flaps. You can use a pericranial flap. You can use a temporoparietal flap. You can use no flap and go with fascia lata, which is of course what Castelnuovo, Piero Nicolai, and Cassiano does. And it works for them. It depends on the defect, and it depends on your experience and what are you looking for. The flaps, they're not magical, but they're a great equalizer, right? So it brings some new blood supply to the area, and it may make inexperienced surgeons a little bit better just because of that. However, you have to look at your experience and see what works for you. I cannot tell you exactly what to use. We don't use the same every time.
Yeah. I can talk?
Yeah.
Yes, go ahead.
Okay. Reconstruction still is a big challenge. So the question is, you need to think about reconstruction as the first part of the operation, not the last part. This is very, very important. First part, think about reconstruction before you start the operation. Create a big hole is easy. To close it is difficult. Especially big defects in the posterior fossa. Defects in the anterior canal base, especially supracell or cellular region, you can close with everything. You have many issues, many tissues to close it. But posterior fossa is a big problem. Especially patient with the previous operation, with the no nasal septum, with the no nasal flap, etc. So because in this posterior fossa lesion, special big defects, only the flap not solve the problem. And this big defect, especially with the previous operation and radiotherapy, this is the big situation, it's a big challenge. So you try to use multi-layers, closure, and then flap, etc. With the lateral nasal flap is necessary. And in this patient, sometimes it's necessary to use a lumbar drainage. You not use a lumbar drainage for other situations, but for posterior fossa, I stopped to use a lumbar drainage, but especially in this situation, you try to use a lumbar drainage for 3 or 4 days. It's necessary in some situations. But If you use a lumbar drainage, it's necessary to do a watertight closure because otherwise and air inside have a big pneumoencephalus. This is the problem of this operation. Since the first option is, the question is, you have a no-nasal septum. So the first question is, if you have a nasal septum, you use nasal septal flap. You have a no-nasal septum, lateral nasal septum. If you don't have lateral or nasal septum, then you use a muscle transfer. The muscle transfer from lateral rectus muscle transfers is really good with the microanastomose with the facial artery, and then create a tunnel and then insert the muscle in the posterior fossa, for example. Not waiting for the patient present meningitis, ventriculitis, many things. After this, it's very difficult to recover the patient. So try to repair this defect very early, not waiting for many complications, because the complications, there are other complications. This is the situation. So this is a very difficult question to answer in just a very few words, but it necessary a very important algorithm experience in the reconstruction. Ricardo has a lot of experience in reconstruction, and for me is the challenge of scope-based surgery, even with the flaps, is the reconstruction, especially in posterior fossa problems.
Absolutely.
Those are words of wisdom. You have to have all the ladder of reconstructive techniques, and they go from free graft to free flap with microvascular anastomosis, as Aldo mentioned.
So Aldo, can I ask you, when did you start using the nasoseptal flap?
Well, I start, to be honest, my thesis at university in neurosurgery was sub flaps. It was in 87.
That's but right. I remember you saying that.
Yeah, I use a small nasoseptal flap to close just sphenoid defects, fistulas, spontaneous CSF fistula of the clivus. But I never published it. Yeah. And then in 2005, Gustavo Haddad came to me to São Paulo and stay a couple months with me and show me one video, VHS video. I like to show you this. This is a very nice flap, etc. Oh, let's go to see you. And stay with me 2 months, and I didn't see the video. And then they showed the video to Ricardo Carrau in Rosario, Argentina. And Ricardo is much more smart than me. And then Ricardo said, "Oh, it's a good idea. It's a very good idea. Let's go to publish it. Let's go to publish it."
It's true. And
you remember Aldo, when I first came to Brazil, 1997. I'm going to show. I still have the CD here, and you can watch it right here. And Gustavo gave me the CD. You remember that? Yeah. This was in 1997. I still have it. Right? And he gave it to me, and he used the flap to basically cover a pseudoaneurysm, and he begged me to look at it. I came back, and it was lying in my drawer for about 3 years before I looked at it. And by that time, our friend Ricardo Carrau has stolen the show.
No, Ricardo is much more smart than us. Yeah, he's much more smart than us. But at that time, he gave him one VHS, not CD.
Yeah.
But one important question and comment, Ricardo and all the people on the panel, is for me, flaps was created initially for closed duro defect.
Yes.
But for me, you have more important use of it. Cover the snoot bone, and especially cover the internal carotid artery.
That's right.
This is very, very important. Especially tumor that extend lateral to the cavernous sinus, you need to expose the internal carotid artery in many circumstances, in many operations. So clavis cordoma, etc. So even if the patient presents no CSF leak, I use flaps, because you can protect all this with the vascularized tissue. So if a patient needs a radiotherapy after, especially tumors that involve the cavernous sinus, you can remove it completely. It's absolutely essential to protect the internal carotid artery. I don't know if you agree with me, Carrau.
I'm sorry, I missed the last part, Aldo.
Yeah, he was ready.
Me.
Oh yes, definitely so. Before it is something that we have changed the way that we do things, in the way that at the end of the surgery, everything is covered with epithelium. And if you do that, all the crossing disappears, damages, delayed injuries of the carotid or delayed blowout of the carotids disappear, et cetera, et cetera. So I couldn't agree more. We started with the CSF leaks, but now is to really reconstruct the entire sternonasal corridor.
Can I ask a question, if you don't mind, to Janki Ram? I would consider Janki Ram as a second generation surgeon, second generation, because I think he used to be.
You are old, Seti.
Yeah.
You are very old.
So, I'm very old now. So, Janki, I just wanted to ask you this. What would be your advice to all these young people who want to become skull-based surgeons? Just starting off. And can you just give them a few tips from your experience?
My experience, I would just say only one tip. Just go and visit all three of you. That's it. And you will become a great skull-based surgeon.
No. Let's just be serious. Let's just be serious about it. Okay?
I'm very serious about it.
No, nobody can become a surgeon by watching somebody else. You know that. Training is a laborious process. There's no shortcuts to it.
But
there's no shortcuts to it.
The baseline is that you have to get trained to see good surgery. And I think the big dons are all here. And I had the opportunity to visit all three of them, and I have been lucky. And after that, you come back and start doing a lot of cadaver dissections, and start from level 1. As all of you say, start with basic cases like CSF rhinorrhea, and then go for small tumors. Don't go in for posterior fossa straight away. And you have the levels of learning, level 1, level 2, and don't jump onto the levels, and always have the help of other people. In case of emergencies, I usually either mail or text or phone up to all my mentors. It's more important. And
I think
yeah.
Go ahead.
And always work as a team. When your neurosurgeon is there, you have him giving opinions, you can give opinions, and that way you progress as a team. I think the team is more important than an individual. This is what
I think the key thing here is knowing your anatomy. Most important. And anatomy doesn't come from reading the books. It comes from going to the dissection hall and dissecting cadavers and learning the anatomy firsthand. I think that's the key to it. And then, of course, a graduated learning process starting from smaller cases and subsequently graduating to more complex one. I think Pittsburgh has come out with a very nice learning modules for training. Ricardo, you want to make a comment on that, on training of the Pittsburgh modules?
Yeah, I think that's what has been mentioned is more or less the scheme. I think that you need to go to a course, start with that, with the dissection. Doing just dissection without the purpose, it doesn't really help that much. You have to be insightful. You have to see where you do the things really become second nature. You go back to surgery, you go back to a course, and you advance in different levels. I mean, Janaki, he was not joking. For 2 or 3 years, I would see him in every course.
Yeah. I have attended 8 of your courses. And I've attended 15 of Professor Sethi's courses. Sorry.
And I would see his learning curve too, right? How I would see it, he would bring pictures or cases, and he would have different questions. So when you start, you have different. You're worried about technique and instruments and things. Once you pass certain level with that, then you start thinking about the preoperative evaluation and the postoperative care, and you keep advancing in your levels, not just in the technique. I mean, the technique, I think that I'm still advancing in technique. Every year I can do things that I couldn't have done a couple of years before. So that is a continuum until you retire or your brain goes bad. But the other aspects of it that sometimes makes it even advance you even more is what he mentioned. Visit other people and see how they do it, because you see again what I was mentioning before. You see the entire puzzle. When I can present the technique to you, or Aldo presents the technique to you, you're not seeing everything. You're not seeing the before and after. You're not seeing the entire pieces of the program, and then sometimes it's a different concept from what you had in your head. I mentioned before the Castle Novo. When they started telling me that they only use the free grafts for the anterior skull base, I have tried that before, and I was not able to do better than 10% CSF fistula. Then I went to visit them, and I saw how they do it, and it's a completely different thing than what I had in my head. They use a multi-layer with very really sophisticated way of doing it, and so you learn from all these little things.
I think Janki's point is very well taken, that you can't live in your cocoon. You have to go out and see, visit the world and see what other people are doing there. Soma, can I request Jolene to unmute himself and show him, because he's the chairman of the meeting after all, and we need to have just a couple of words from him, unless he has already given that.
Is he able? He did do that briefly just now, but
all right, then I'm sorry, because I joined late. So if he has done that already, that's great. But he can still unmute himself, you know.
That's right. Yeah. Prof,
okay. So how are we doing for time? Are we okay?
We've got another 10 minutes. Can we take one last question?
Sure.
Okay. But what I would like to do in future is, Soma, that the speaker has access to the questions, so he can see the questions himself and then answer them accordingly. So I think it would be a good idea.
Questions in the audience.
Dr. Carrau, just take one last question if you don't mind before we wrap up. And I think it's the question about the middle turbinate and whether we should be resecting it routinely and whether we should be using it for reconstruction. I can probably help you there, because I think it's very important for the participants to know that the middle turbinate is not resected routinely. And in fact, we preserve it most of the time. It's only when the nasal corridor is very tight when you really need to resect it. And even in that situation, we actually reuse it as a free graft to actually cover a lot of this blood. So Dr. Carrau, do you want to chime in on that?
No, you covered it. I mean, Soma was with me for a year, so he knows how we do things. Yeah, that's clear. So don't resect it routinely.
I've shown a few, I've showed a few videos of the middle turbinate being
he even holds the scissors the way the Pittsburgh people hold it. I told him, why don't you hold it the other way? He said, no, Amin and Ricardo hold it this way, and that's the way I want to hold it, So there are a lot of carbon copies out there.
Teach
like this, no, they hold it like this, and this is the way I'm going to do it.
Yeah. So that's always very controversial about the middle turbinate, because the rhinology point of view is preservation and olfaction, and indeed, even for skull base, we try to preserve it most of the time. It's not that it's routinely resected. Does Prof Aldo Stam or Janika, any comments on that?
Yeah, just a short comment about this question. This is a very important question, because these ENT people are very interested in how to approach in the corridor of the skull base surgery. So this is very controversial issue, discussion, even for sinus surgery. Remove or not remove the middle turbinate, not only for skull base surgery, for inflammatory disease, for infection diseases of the sinus, always the same question: remove or not remove the middle turbinate. So the question is clear for me. If you address the nasal septum, is in the great majority of time is not necessary to remove the middle turbinate, especially for the middle line ventral skull base lesions. Of course, if the tumor extends laterally, especially for example, cavernous sinus extension, other situation, orbit, etc., you need to expose much more. Of course, you need to remove the middle turbinate. So the lesion explains to you what to do. But in the great majority of time, especially for tumors located in the cellar, restricted the cellar and the supracellar, for me, in my impression, is our experience, is not necessary to remove the turbinates. You can displace it, you can reduce if it is necessary, but the great majority of time is not necessary to remove completely.
Yeah, can I ask one question, if you permit me, Dr. Soma?
Yeah, 5 more minutes and then we'll wrap. Yeah.
We generally don't find the septum in the midline most of the times. Maybe unfortunately, my cases are never in the center. You have a huge septal spur, or there's a very bad septum, and in such cases, sometimes we land up in a tear along the spur. So in such cases, what do you really do? Do you actually take a bite or suture that tear, or you just allow it to be there and then put the the distal part of it on that? So what do you do when there is a tear right in the middle of the hana or the nasal septal flap? Anybody, please? Any of the panelists or moderators?
Dr. Carrau first, if you don't mind.
Yeah, so if you need that nasoseptal flap and you have a tear in the middle, we try to suture it. Or you can use some clips, or you can use some other technique to do it. If it is a small hole, you could also use a fat plug to repair it. But for the most part, you have to take care of it. Sometimes it also depends on where the tear is. Sometimes the tear is not in the area of the paddle of the flap, and we just leave it alone. Or if we can move the tear to a place that is not going to be in the CSF, that would be fine. Another technique is use a combination of grafts and flaps, and just leave the tear alone. Just put something at the other side so it doesn't leak. So a variety of things you can do. It just depends on how big the tear and how you're going to use it.
I think size and location is the key thing.
Well, just a short comment, Seti.
Yes.
I agree completely with Dr. Carrau about this situation, about the tears of the nasal septal flap. Of course, this is the most important is the margins of the flap. You have a small tear in the middle. It's usually has no big problem when you do this have these tears in the flap. So it makes no big difference for me.
The thing is that if you have a big spur and you have the ability to do it on the other side, to take the flap from the other side, that's what we do. So as Aldo was saying before, the reconstruction, you should think of it at the very beginning of the surgery and have a plan A and a plan B and a plan C, and that's part of it, is which side are you going to do the flap from?
Yeah, I'm sorry, Ricardo. This is why before you start the operation, you decide what side you'll do the flap.
Yeah.
So, can you actually put the brochure, the flyer for next meeting there? That will be better?
It's actually on the screen. Can y'all see it?
No, all right, it's okay. Great. So, guys, it's actually we're going to have the same team next week. Ricardo Carrau going to be the moderator, and they're going to switch roles. And Aldo Stan will be speaking. So, Ricardo, you'll have the time to grill him next week. Okay.
I may not be able to join you next week. It's my wife's birthday, so I have sent a message before that I may not be able to join you for the next week panel.
Yes.
All right, so it's okay. Then we can. I think we'll have a replacement then. Maybe Ricardo can give us another talk then.
Yeah, I have plenty of opportunity to harass Aldo in some other meeting.
Fortunately.
But Aldo, yeah, you are one of our panelists, and you got to be there for all the talk as far as possible, because we really want to tap onto your expertise, your experience. I think the entire Asia Pacific, is looking forward to input from you, to learning from you, and from both of you, in fact. And that's one of the reasons why we have this webinars. We've been conducting this SARC meeting for the past 10 years or so, I think. And this year, because of the pandemic, we couldn't do that. But they say that one door closes, several others open, and one door closed and thousands open. We have hundreds of webinars now. I've been attending webinars like from 6 a.m. to like 10 p.m. at night during the lockdown.
Well,
but it's been amazing. It's been really amazing. What you see is amazing is that there's so much of talent out there, which we never knew existed. So much of talent all over the world, and Zoom and WebEx has really connected us. And, you are sitting in US, and Aldo is sitting in Brazil, Janki in India, and we have, attendees from all over the world. This was simply not possible when we used to have meetings and conferences, So it's amazing. It's really, I think I'm really fascinated by this teaching tool that we have here.
Prof Seti,
Yes.
can we have Dr. Leong to say a few words before we wrap up?
Yes, absolutely. I think he should, because I didn't hear him talk, and I would love for him to say a few words.
Hello, Chindan, are you there?
I think he's getting tea break. I think tea
Okay.
break. I meant.
Yeah, he did say a few words earlier, and I think we can't get him right now. So, so on behalf of the organizing committee, I would like to extend my gratitude to Dr. Carrau for making it up early this morning. A fantastic talk as usual, and great panelists, Dr. Janakiram, Professor Aldo Stam, Professor Seti. So I think this is a great start, and I think we'll continue this next week. So for the participants, there's a lot more questions that are coming in right now, but we've run out of time. So hopefully we can have questions coming in a bit earlier next week. So same time, same place, 5th July, 7 p.m. GMT +8. So
I think, Soma, we should keep their questions, and we should try to answer them through emails, or maybe try to answer them next week. They should not go unnoticed, and we need to answer those questions. Okay.
Sure.
So keep them in the database so that we can try to answer them next week.
Yeah. Okay. Thanks, everyone.
All right, great. Thank you very much, Aldo, Carrau, and Janki.
Thank you so much.
Thank you so much.
Thank you for making me a part of this panel. Thank you very much.
Have a good Sunday. Have a good Sunday, everybody.
And we had a beautiful evening last night, didn't we?
Yeah, it was fantastic. It was fantastic. I really enjoy. I really enjoy. It was great.
Thank you so much.
Bye. Thank you very much,
Okay,
all the
bye-bye.
people.
Bye.
Bye. Soma.
Thank you.
Bye.
Thank you.
Thank
Bye-bye.
you. See you.